This is a view from my desk on my iPhone. This is what I get to look out at on some days, not every day, as you know. Here's what we're going to talk about. If I can figure out how to do this. Here we go. So a little bit about disclosures. Official things. I really don't have any current research or consulting with any of the SAS companies. I've had past things. In the last month, I've used 4 companies' products one way or another. I really do think that stimulation can be a fantastic thing for patients. And so I'm biased. I do it. I think it's good. I think it's good in selected patients. I think it can be a disaster in patients who aren't well chosen. I have not done DRG stimulation, and I have not used a new vector stimulator or stim wave. And eventually I'll be able to get this in my pocket. Boom, it'll be good. Now I feel better. I can move around. A little bit about me. When I was a trainee, there were, I think, hardly any anesthesiologists in the country placing spinal cord stimulators. And that was certainly true at my institution. The reason I first did one was there was a neurosurgeon very interested in stimulation. He was getting busy, and he said, I'm really good at the implant. I'm not so good at the trial part. Can you help me with the trial part? So I started doing trials with basically modifying an epidural technique and putting leads in. With him at first, the first one with me, after that on my own. Then he left, and then his colleagues said, we're also worried about where to put the paddle, so I started going to the OR with them. They would do the laminotomy, hand me the paddle, I'd put it in, we'd wake the patient up, stimulate the patient, I'd move it to the left, the right, up, down. Say, that's good, step back, that was my whole job. Then I moved to Portland, and in Portland, the chairman of neurosurgery who trained here with John Lozier, Kim Burchell, said to me when I was interviewing, these are easy, you don't need a neurosurgeon. I will proctor you, you can do it on your own. I'll give you a year to be flying on your own. So first year, I'm 6 years out of training, but it's like training again. It was great fun, and since then things have gotten better. So that's where I am. That's how I got to be doing what I'm doing now. So I'm going to show you a bunch of pictures of leads. And these leads are placed in a variety of different situations for a variety of different things. And some of them, you may think that's a really weird lead configuration. None of them were put there because, some of them were put there because that's where I planned on going. Other ones are because that's where stimulation led me or anatomy led me. So don't be judgmental when you look at these. Okay, and I really didn't select these. I just picked a bunch of random ones since I've been here in Seattle. So first thing, what are the goals of the trial? You've already decided you think the patient's a good candidate for SCS, hopefully. You're going to find out if it really is truly an implantable system is a good option for them. And you also get to see what your patient's like under the stress of a trial, which is a different world than seeing them in clinic. You can decide where you're going to put the permanent electrodes. You can also decide who's going to put in the permanent system, me or a surgeon, or a neurosurgeon, or an orthopedic surgeon. So how do you define success? In the literature, it's typically defined as a 50% reduction in pain. I think this is a good baseline, minimal, must clear that bar outcome, because anything less than that is not supported by the literature and will not be covered by most insurance companies. I think it's a minimum baseline bar. If someone gets 53% pain relief, A, it's false precision, and B, show me that that's going to be sustained, because I don't believe that for a second. I want them to sail over the bar. So I like much more than that. And I also like it to be accompanied by other changes. I reduce my PRN medications, I'm walking more, I'm sleeping better, I feel better, my wife says I'm not as grumpy, whatever it is. I want some other outcomes in addition to just pain relief. There are huge variations in the way trials go. If you've done trials, you know this is true. So there's some trials that are quick and easy, boom, boom, spend 20 minutes, you're done. You're like, what else can I do to spend more some time? Here, you're done. Others, you're struggling and sweating, and it's really hard. And those challenges come from the patient, come from anatomy, come from systems, come from all kinds of things. You want to make sure that most of the challenges are coming from what the patient's presenting to you, not your ability to get where you need to be. So some of that involves planning. So this is a real patient here in Seattle that I did. I thought about this quite a bit before saying, yeah, let's go ahead and give this a go. And I'll show you the later slides. And this patient ended up with a successful trial and I, not surprisingly, referred her to a neurosurgeon for implantation. So you can put temporary leads in, 1, 2, 3, 4. The goal of traditional stimulation is, of course, to provide stimulation over the painful area. For high frequency, you don't get any feedback because there's no sensation, so you put it by anatomy, covering T9 to T11, possibly a little bit lower if you're looking for primarily neuropathy pain in the feet. There's some data to suggest that. I also try to achieve insurance approval in advance and think about what I'm doing. So if 2 leads are not covering what I need to cover, I'm happy to throw in a 3rd or 4th lead. I went because the patient's going to get 1 trial, you do the 1 trial. So back in the day, this idea of putting in a surgical temporary lead. You make an incision, you anchor it, use extensions to come through. That was pretty common. Percutaneous trials where you throw away the lead no matter what you do were not as common. Turns out that making an incision and planning something tunneling is associated with 2 outcomes you don't like. More infection, the patient more likely to say, yeah, let's go ahead and do the next step because we're already halfway there, and then not being as happy with it. So less good outcome. So this is a little overview, then we'll go into more specifics. During the trial, I tell people no BLT, no bending, no lifting, no twisting, and please, please, please keep the insertion sites dry. You cannot take a shower and keep the insertion sites dry. So keep the insertion sites dry and the dressing dry. The trial duration can be really varied. It can be really short, or it can be a couple weeks. We'll talk about sometimes when they get to be longer and why that might be. During the trial, the SES is adjusted either via an algorithm or based upon patient feedback to get coverage and pain relief. And then I suggest some form of basically daily contact with the patient to make sure everything is on track and nothing bad has happened. And then at the end, there's judgment. I really like what Ramon was saying about you have them come back, you take the leads out and say, okay, I'll see you in a week or 2. We'll talk about our next steps. Some patients just want to gush about how great it is and want to talk about right then, want to plan, let's move forward. I'm from 300 miles away. I don't want to have to come back for another visit. You know, you have to kind of accommodate what's there, but I like the idea of having some time to think. The other thing that's unique and different is if at the end of the trial, your set trial period, a week or so, the patient's not saying this is fantastic, you have leads in, try something different. After Boston came out with their OMG, which I have no idea what it stands for, but I think I do know what it stands for, a system where you could hook up Boston stimulation to try it with other leads, everybody else has figured out this is not a bad idea. So I say, the first trial is not a home run. Why not try a different mechanism of action and see if they like it better or turn a non-success into success? And remember, your patient is going to get about 1 of these. They're going to get 1 trial. It's your job as a healthcare provider to make sure it's the best trial you can give that patient. And they have all the information they need to know to decide their future life. What's going to happen in terms of stimulation. So do a good job. This is a lot of words, but there are a lot of really good words. And I put them here rather than at the implant one so we can kind of go over them real quickly. So the first one is, you should be trained. Good idea? Anybody disagree with that? Kind of trained, credentialed, that kind of stuff. And then you should also know your community standards for stimulation. You should work with a team in the OR that knows what's happening. And that, of course, there's a committee of people who do stimulation saying we should think about stimulation before thinking about long-term opioids. That's the most controversial thing in this whole list. And then you should treat patients in an interdisciplinary fashion before going to stimulation. You should use appropriate selection criteria, which includes a psychological evaluation. And then number 8 is an important one. Patients' wishes regarding cosmesis, choice of implant, and timing of surgery be considered as part of the preoperative and intraoperative planning. If you have a company you use, you can't offer your patient number 8. So you really have to have options for your patients because there are options in the world. And so I think you have to offer your patients options and talk to them about the differences in these options. And then you should have, in advance, to have what they call a discussion about the risks and alternatives and have a consent signed. Next, you ready? That before trialing, you plan what you're going to do with other healthcare providers involved in the team. Use a pre-op checklist so you don't forget to do anything. For permanent device, what's this one? Do a trial first, which makes sense. And then before putting a lead in, you should look for the risks of bleeding at the anticoagulation. That you should use a sterile environment, which isn't really surprising. You should hopefully have the patient give you real-time feedback, even if you're doing laminotomy approaches. You should give them preoperative antibiotics, not surprising. You should care for the patient pre and post-operative, that it's people who know what they're doing do the programming, and that you should make sure that you have a quality control system. Hard to disagree with any of those things, but you need to really think about all those steps before you touch the patient the first time. So before you touch the patient for the first time, first know what you're trying to target and make sure that your stimulation is going to cover almost all of their pain. Because they often will tell you, oh, my neck pain doesn't really bother me much. It won't bother me much until 3 months later. There's this thing called the battlefield promotion, which is whatever is number 2 becomes number 1 when number 1 goes away, right? So my number 1 pain's better, and now my number 2 pain, man, I can't stop thinking about that neck. So you need to, or my headaches, or whatever it is. So you need to make sure you're covering most of their pain. Really do the psychological evaluation. There used to be, like, a suggested thing was good practices, but now in the last 5 years, there's been a whole bunch of literature coming out saying that psychological factors really are major predictors of patient satisfaction, outcome. Everything about their outcome relates to psychological factors. So you need to really do that and look at it and think about it. Identify and treat remote infections. Assure that they have normalized coagulation status, good diabetes control, and think about tobacco cessation. Often recommended is tobacco cessation. Give weight-based antibiotics. Make sure you position them in a way that's going to allow easy access. And of course, do surgical scrub and use sterile technique throughout. Needle entry. So we have this, some of the radiology techs I work with save every single image. So there's like, I opened up with some of my recent patients and oh look, there's 30 different shots of everything. So here's a needle trajectory, which is a shallow paramedian. You can use different types of needles, of course. There's a curved tip or straight tip. I personally really like a curved tip needle, and any of the fellows that work with me will tell you that I can't do any procedure without a needle tip curve, so I can steer it and turn it, make it go wherever I want to, whether I'm doing ultrasound or anything. Where to go? Usually you want to go above the side of the previous surgery. That is not always completely an option, and I'll show you some pictures with that. You'll commonly be told to start at the pedicle of the level below the planned entry, right? So go down, come off to the side, and go in. Remember that body habitus varies quite a bit. So a really thick person, that's still going to be a pretty steep angle. A really thin person, that may be a little on the shallow side. You have to kind of judge and make a little triangle in your brain about where you're going to start and how you're going to go. And you also have to look at the select a space that looks amenable to you getting in. You advance towards the midline. I usually touch the lamina, then walk off. I walk off, switch over to loss of resistance. I use saline. Others use air. You advance. If you feel anything, you should start checking. If you feel nothing and you feel like, gosh, I've gone a long ways, you should also start checking. You should check contralateral oblique, or a lateral view. Try a lead blank, something to see where you are. Sometimes the loss of resistance can be difficult to obtain. This can be because it's an older patient with lots of calcium between you and them, you and the pay dirt. It can be lots of different reasons. So before you give up on your needle entry, adjust, change within that same level. You redirect the needle to a different aspect of the space. If they're thin with one needle entry, you can often redirect to the space above without even pulling out of the skin. Still no luck, go a different level or try a different approach or do something different. You can, if there's only one place you can get in, you can put in 2 needles to the same place, to the same level if you need to do a 2-lead trial. So there's lots of different ways of seeking this out and finding it. And then you need to put it wherever it needs to be. So anyway, as you're doing this, you do not want to image your hands. You do not need to see the whole needle. You need to see where you're starting. You don't need to see everything else. That's one thing. You advance under, of course, pulsed or live fluoro. Use the hand closest needle to advance. The other one is the primary steering hand. But when it's difficult, you have to use both together in concert to make that happen. Don't advance and think, I'll just steer back. If it's not pointing where you want to go, please don't advance it. It's not going to help you. You'll find the anterior epidural space, for example. A straight path is the best path. If you need to, change stylettes, add a curve. If it's tough, take what you can get. So that upper picture, do you think I intended to cross those leads? No. Do you think the fellow who did that intended to cross those leads? No. Did it end up in the posterior epidural space in a reasonable place? Yeah. So I said, let's just, since we spent a little bit of time getting here, let's just leave it there. It wasn't so easy, and we ended up doing this interesting cross lead thing. It worked fine. And then know your target. Sometimes you're in there and you're going and you think, where am I going to stop? Am I going to go to T7, T8, T9? What am I doing? You should kind of have an idea in your head what you're doing before you do it. And more than have an idea, have a plan for what you're going to do before you do it. And that plan really varies with where the pain is and also a little bit with what the device you're putting in is. And if you're going to put a second lead, repeat the process for lead 2. You know, leads are varied. Most of the time, they're 8 contacts. There's a 12 contact lead. There's a 16 contact lead. You can, if you wanted to put in a 4 contact lead, you're welcome to. So there's lots of different lead choices. So decide that in advance, but also know where you're going to put that lead. Unless you're doing a no stimulation technique, you're going to then trial stimulation during lead placement. And you have to do this because spinal cord anatomy and physiology is variable. You do not know where midline truly is for this patient. You do not know if they're going to perceive a bunch of unpleasant abdominal stimulation, even though it looks like you're right smack dab on the midline. So you really have to do this. And then you have to reposition the leads to idealize stimulation if it's not perfect. And that can be up, down, to the left, to the right. And the goal in the room is not to get pain relief. The goal in the room is to get coverage. That I'm covering with appropriate stimulation all your areas of pain. Pain relief comes later. I don't really totally care if they say, this is, you know, this doesn't, yeah, I feel it, but it's not, I still feel my pain. That's okay. That's what programming is about. Your job is to get it in the right place. Sometimes the reps will want you to think that close enough is good enough. I completely disagree with that. You want it to be as good as it can be. So good placement makes everything better. And the ideal is to have more than one set of contacts covering. And hopefully, if you have 2 leads in, both leads providing something beneficial. You don't want the top couple of contacts being the ones that are the best because during the trial, if leads migrate, they almost always move down. As I said here, if they move up, that's a case report. It doesn't happen that terribly often. They usually move down. They can move up for a couple of reasons. One is you have taken a deviating course and now it straightens out. The other is something weird happens with the way the dressing is, and just they have a very easy sub-Q space and just slides right on in. So you want the kind of the middle of the contacts to be the ones that are the sweet spot, maybe even the ones a little slightly lower than the middle ones, and you want to make your best effort to make it as good as it can be. And sometimes 2 leads aren't enough. So this is a recent patient. He had 2 different pain conditions. He had previous lumbar fusion, low back pain with some radicular symptoms, and he had peripheral neuropathy. I tried my little 16 contact lead all over the place, and I could get feet or back, feet or back. I could not get both. So I said, okay, I'll use that one for the back, put it up, and he said, that's getting my back right where I need it, it's perfect. Put a lead in, tried to put it in the middle, only felt it one side or the other, so 2 leads. 2 feet, another lead for the back. So you have to do what you need to do for the patient. So in the room, I think you can glean a lot from what's going on. So if the target is small, really, really hard to find, or in a location you weren't quite expecting, that's not a good sign for the long term for the technique you're using right now. If the patient is intolerant of the whole process, they don't like being in the room, they don't like being prone, they don't like having you touch them, they kind of scream when you put the local anesthetic in, even though they have some sedation on board, this may be a little bit of a challenge ahead of you. If nothing about the stimulation feels good at all, that's not really a good sign, even though I said earlier I don't care about pain relief initially, I do care about tolerability a little bit. On the other hand, there's the people you put the lead in and they go, you turn it on, they go, wow, that's good. It's perfect. Let's try the upper part of the lead. Oh, that's really good too. Let's try the lower part. Oh, yeah. That's a little bit different too. I like it though. It's right where I need it to be. You know, like those folks, I'll take those every day. That's fantastic. We all like that. So once you're done, then you need to secure your leads and save your work. I don't care about your memory or your report. I want to see the images that tell me where the leads are and where you left them so I can know how to plan in the future. So if you've done many trials, you'll think, gosh, that lead looks a little bit low. It's a little bit low because it's a neuropathy patient, and there was some data that suggests maybe going a little bit low with that. Lower lead might be better. So I go in, my little standard is to put a needle across a T12L1 disc space. I always know it's a T12L1 disc space. And then if I'm working with a tech that knows how to do this, I say, please label T12 or L1, one of the two of them, whichever works with where the leads are. And I save an AP in a lateral view. You really want them to stay during the trial. So I always remove the needle and the stylet under fluoro. And I'd rather have the leads slide up a little bit during this process because you can always pull them down. It's a little bit harder to move them up, pull down. I typically use a stay fixed dressing and then clear occlusive dressings. And as soon as I've made it sterile, I hand it over to the nursing staff and the rep to do the rest of the dressing however they want to hook up their stuff for the trial. And I don't take that final image until the needles are out and the dressing's on. I don't care what it looked like before you're done. I care what it looks like at the end, because that's what the patient's going to live with. And then the trial instructions. You have to tell the patient, you're going to go through several programs. I don't care if the first one's fantastic. You're still going to try some other stuff. You need to stay in touch, have them call for problems, take care of the leads, remind them of the BLT restrictions, bending, lifting, twisting, keep the dressing site dry. I tell them, take it easy on the day of the trial, but starting the next day, start doing things that don't involve BLT to test it out. And then make sure that if they're using PRN, quote, pain medications, that they're using them truly PRN, which is not just, oh, it's time for my drug, time for my pill. You know, if their pain control is better, then why use that? So really, I do that. And I, myself personally, do not prescribe opioids for procedural discomfort with the trial. Others do. Then you get the patient that tells you this. Well, it's helping. Yeah, it's doing something. So the relief's not dramatic, and the rep tells you they have been through most of what they have to offer. So have the leads moved to a different position? Is there some factor with the patient that is making them not being able to get relief? Are they noticing other things that are different beyond just pain? So I ask them a whole bunch of things about the stimulation. And also at this time think about switching to a different system with a different mechanism of action and see if we can extend it further. If it's a home run, you want to move forward. The patient has dramatic pain relief. They say that my function's better. I don't care if just on the last day of the trial they say that. I really want to be more than a day to decide to make the big commitment. If you're gonna go to implant, make sure you know exactly where your contacts are, where your leads are, so you can mimic that at implant. And then you need to decide how to move to permanent. If the trial was really difficult and you felt lucky to get in, then why hope for luck in the OR? Because pulling off a little piece of bone from the neurosurgeon, that works pretty much every time. So I say, if you felt lucky, don't do it. If it was easy and you're doing implants, then go for it. If it's somewhere in between, decide on your skill level and what you think. And then discuss the options with the patients. Tell them there's two ways of going forward. I do this. I can see a neurosurgeon. Here's the differences in the systems. Here's what you would expect. In the state of Oregon, where I used to be, we have this thing which is actually codified in the state regulations called the PARQ discussion, P-A-R-Q. You talk about the procedure, the alternatives, the risks, you answer the questions, and then you sign a consent, right? Nice process to go through. At a PARQ discussion with the patient. So procedure, discuss it all. You know, laminotomy versus percutaneous lead placement, procedure in detail, post-op recovery, activity restrictions, possible complications, long-term outcomes, what maintenance of the system is going to be like, how they have to interact with it, MRI issues, outline the other treatments you expect them to have. Because back to that question at the end of the last session, if all you do is put a stimulation system in and say, okay, see you, bye, that's not everything your patient may need. They may need to then be shown how to take full advantage of it to regain their life. So you need to kind of talk about other things you can do to do that. Then you always have to have a plan B, because it doesn't really always go as you planned. So if you can't get in where you plan on going in, try lower, higher, left, right, different needle, et cetera, or maybe even different operator. If you have a colleague, patient's here, this is their one chance, and the colleague happens to be able to kind of walk in and kind of give you a hand, try it. Be reasonably persistent. You may have optimistically scheduled this for less time than it's taking. You may think, I'm screwing the rest of my schedule. Be reasonably persistent. Give your patient the best shot you can. If you can find the epidural space, but you can't find the midline with the lead, think about creative ways of doing that. Come back, access the epidural space, same level, but on the other side, different angle, change your needle bevel, do something. If you want to advance, what are you going to do differently? Think about all these things. If you get a wet tap, what are you going to do? If you can't find stimulation, like you're going up and down, left, right, and the patient says, I feel it in my abdomen, I feel it everywhere but where you wanted to feel it. What are you going to do about that? Sometimes I end up, if I really have searched everywhere, I put it what looks anatomically to be the most reasonable place, tape it, say, let's go see what it's like when we program afterwards. If the patient is uncomfortable, not very cooperative, or has a vasovagal event, and some of you may know what I'm talking about that, the recent experience we've had, just know how to handle that. And sometimes medical events happen, right? Sometimes we're doing these on not the 25-year-old person with a nice isolated problem, but sometimes it's older, more compromised people. And there really can be equipment problems. I've had a C-arm break. Guess what that was like? Effing disaster is what that was like. So things happen. So you have to have an idea of how you're going to have a backup and plan.